Becky Cooper, please.
Thank you, Chair. Thanks so much for being here. So we heard in our previous panel about the relationship between local authorities and integrated care boards. So I'd like to start the questioning by asking for your thoughts around your relationship, the voluntary community and social enterprise relationship with commissioners and providers. Is it a genuinely good relationship? Is it an equal relationship? Are you equal partners? And if there is room for improvement, what areas, what policy levers do you think would enable that improvement? So perhaps if we could go along the panel, starting with yourself, Duncan.
So it's not an equal relationship. It can't be an equal relationship because I think it's premised on, in the first instance, the commissioning or the procurement of services. I think the extent to which it's a good relationship varies in parts. So, for example, in some parts of the country, we've seen the community mental health transformation agenda or narrative translated some, I think, probably more meaningful, authentic relationships between VCSE organisations, local authorities and the NHS.
If I can ask you, what facilitates that? Why is it there?
Well, so the example I'll give you is probably in Durham, where the leadership arrangements or the facilitation of the voluntary and community sector's engagement in community mental health transformation has been led by the local authority. And it's the local authority that's invested in the VCSE alliance there. I think there will be other examples in other parts of the country, for example, North East Somerset and the work that's been led by our colleagues in Rethink, that will exemplify the extent to which some colleagues in the NHS have facilitated meaningful and authentic engagement of VCSE organisations. But in many instances, I think the default will be to those larger providers, and many of our smaller members, particularly those working in specialised services, may have felt excluded for some of those alliances and indeed the discussions that have led to them.
Okay, thank you. So I'm picking up there's definitely a strong relational element there.
I think there's a relational element, and it points to a wider issue about there's an acute and ongoing focus on the system and the structural requirements in relation to improvement of services. And I think your previous witnesses today have alluded to some of the behavioural and the cultural considerations that are critical. And those are embedded, I think, in the power relationships that we've talked about. So a stronger focus on cultural and behavioural. And indeed, earlier on, I think the committee chair referred to the extent to which there should be perhaps a greater devolution of responsibility for delivery. I think we'd like to see some clearer focus on some national outcomes and some national expectations in terms of the nature of the integrity of those relationships and the extent to which local systems are held to account, both in terms of the investment in the VCSE sector and the authenticity of the agreements that deliver those.
Thank you. Stephen, any further thoughts?
Yeah, I mean, Turning Point operates across the country, so we have lots of different relationships with lots of different ICBs. My experience has been one of non-equality, but we have to put it in the context sometimes of the size of contracts that VCSE organisations work in a specific area. So you've got an ICB, and we might have £1 million worth of business in that place, and obviously the NHS have got 100 million or whatever. So there's something about proportionality that I think is really important. And there's also something about just the sheer amount of VCSE organisations in any one area, and then you think nationally as well. So it's very difficult to get a single voice because we all have slightly different ways of thinking about things. So I completely agree with Duncan's kind of posit that there needs to be some sort of national outcome tool or measurement that kind of brings people together so we can not measure ourselves against each other, but kind of together see what works. Mm-hmm. And without that, I don't think we'll ever be in a position where we can be at the top table in the ICBs. I think we're too small and individual. Duncan's organisation does some great work in bringing us together, but you only represent a small amount of the plethora of different organisations out there.
Okay, thank you. Penny, any further thoughts on that one?
So we're a national organisation. Our partnership working is directly with NHS trusts and local authorities rather than ICBs. Mm-hmm. I would say in terms of that partnership working, we have some brilliant partnerships, but the one big challenge is about that multi-year partnerships. Unfortunately, because as a charity, our funding is uncertain, and we're working with partners whose funding is also uncertain. So long-term partnership is always going to be very, very hard when you're working in that context. And I would say that's got increasingly challenging in the last year to 18 months, where NHS Trust that we've had long-term partnerships with are unable to partner with us, citing financial reasons. And that is definitely something that has become more pronounced in the last 12 to 18 months. And so that kind of multi-year partnership working where you really get to know each other, you really get to know what the local population needs, and you can adapt your work to make sure that the partnership is most effective. That just isn't possible when operating with such funding uncertainty.
Yeah, that's really helpful, and we might come back to that later, I think. So if I can just move on, and perhaps, Penny, I'll stay with yourself around the Department of Health and Social Care and NHS England in terms of how they are facilitating that relationship and helping you. And you've talked about national structures and national targets. In their written evidence to ourselves, they have stated that there has been a substantial increase in the involvement of VCSE organisations as partners in the delivery of holistic care for people with serious mental health problems. So they think that things are improving in general. So Penny, I wonder what more you think they could do to ensure perhaps that VCSE organisations and providers can feed international policy and be a further part of that conversation, and whether you think it is fair to reflect that things are improving generally.
So as a charity, we're funded by the Department of Health, and I think in terms of reflections about how we could be better utilised, we've been going for about 10 years, and in that time we've built up a huge database of 100,000 people across the country who want to work in mental health. We've got a ton of metrics and data about what drives someone to want to work in mental health and what indeed might make them leave the sector as well. And I think where one of the frustrations is that we're not necessarily utilising that data in a partnership agreement with the department or with NHS England, and sometimes it can feel a bit transactional as a contractor who's delivering something and meeting their KPIs and doing the best that they can. But actually what we'd really like is a more collaborative partnership working where we can look at all the evidence that we've built up over the last decade, which is so fundamental to building a really happy, healthy mental health workforce, and share that with the department and share that with NHS England in order to drive policy change, particularly around the long-standing workforce challenges around recruitment and retention.
That sounds very sensible, Penny. So perhaps, Duncan, if I can come to yourself, and perhaps if we can expand this conversation slightly, because I'm aware that AMHP, you've delivered or you've developed a map of VCSE services, and I wonder if you could perhaps tell us how that's being utilised currently, and perhaps at a national level and a local level, and whether you think that sort of can be better utilised to sort of provide improved services through commissioners and providers and that wider national structure.
Yeah, so you're right. So we've undertaken two pieces of work over the last 2 years. One which involves the mapping of VCSE and other statutory services in relation to mental health and mental health social care and support across England and Wales. And we've also in the last 6 or 7 months produced a mental health social care workforce mapping tool that provides some more granular detail on the nature and extent of the mental health social care workforce and the vacancy rates as currently exist, and the need for investment across that workforce, which includes the need for firm and clear investment in relation to social work, occupational therapy, and the wider care and support workforce in relation to mental health. We use the term mental health social care and mental health social care workforce to make that distinct from a clinical NHS workforce, and we think it's a term that's got increasing traction. We're working in partnership with colleagues at the LSE and Manchester University through some NIHR funded work, an incubator project that's looking to further exemplify the value and the investment requirements of the workforce. So we've been encouraged by NHS England's interest in the work that we've done, and indeed that from colleagues at the Department of Health and Social Care. And I think the 10-year health plan provides us with an opportunity to utilise that more effectively at a local level, particularly in the context of the rollout of the 24/7 neighbourhood mental health centres and the aspirations for neighbourhood health and care programmes which DHSC are leading on. And I think which we understand that they are really, really clear that social care and the VCSE will be clear and equal partners in those rollouts, because the success of both programmes are contingent upon that meaningful engagement.
So they're really interesting terms to use. Thank you, Duncan. I think they're very clear, which is great. So the mapping, just to clarify, it is being used currently in sort of national structures, or you're hoping that it will be used further?
So we've got an indication from colleagues currently at NHSC or NHS colleagues that will be returning to DHSC that they see its value, and we hope to be using it with them. And I think on the back of those conversations, we'll expect some colleagues at an ICB and local level to be utilising those more effectively. I think, if I may, it relates to a point that I don't know if the committee has heard today, is that at the end of 2021, NHS England required all local systems to produce mental health integrated mental health workforce development strategies and plans. And that expectation was clear that they should be produced and delivered in conjunction with local authorities and the voluntary and community sector. We're not aware of having seen of any of those, and I think it would be good to see what was produced at the time, and indeed what, if any, intentions there are to reproduce those in relation to the commitments in the NHS 10-year plan.
That's really helpful, thank you. I'm sure that we will all pick that up. Thank you very much. So if I can just move on perhaps with yourself, Stephen, around meeting wider social needs now. So we heard from the previous panel around local authorities, and there was a clear direction from the previous panel around the social determinants of health, particularly mental health outcomes. And we are, of course, aware that VCSE organisations are already working around the social determinants of mental health, and there is some great examples of best practice. And what more do you think can be done? I'm sure there is more that can be done to ensure that local authorities and the NHS are supporting you to more effectively integrate with community mental health services. And if you want to talk about those wider determinants and how you think you can better work there, that would be really helpful. So Stephen, if perhaps we start with yourself.
I mean, I think where it works well, it works really, really well. I've got some really good examples of, for example, a crisis house we've got in the north of England that is just opened its doors to going into A&E services to take people out of A&E so they don't need to sit in there, and that's in conjunction with both the NHS and with local authority kind of agreement. So there are some really good pieces of work that go on, and I see the VCSE work as kind of like the glue that holds the statutory powers and the work that NHS and local authorities do, which are really important work. VCSE kind of hold the glue to that. They're the ones who are actually working with the service users on the ground quite often. They're the ones who have the relationships. They know them best. If you think about a supported accommodation, for example, people are with people 24 hours a day, and so they know them really, really well. And I think the way to help do that more is to allow VCSE people to continue to do that. We were just talking before about short-term contracts and about the nature of 3, 5-year contracts. We are seeing that change a little bit, and we're just looking at some much longer ones, which is really useful, because then we can start to think about how we can help people in the longer term, because I think it's really important for us to recognise that, and Pete Devlin was talking about it a little bit before, that whilst recovery is so important for lots of people, there's a significant cohort of the people we're talking about today who recovery isn't an option in the truest sense of the word. And when you've got short-term contracts, when you've got recovery as a goal, it kind of all leads to that kind of short-termism and not being able to actually get to the bottom of what you're talking about. So in that crisis service, we have a fantastic service user who works with us a lot, actually. And she's quite a high-flying person, but she's got a severe mental health problem, and she needs to come to our crisis service every now and again for maybe 3 days, and then she can go out and she can do her fantastic work again. And I worry if it would be very easy to cut the funding to something like that, because it doesn't fit in the criteria of what statutorily people are supposed to have to deliver. We're subcontracted. Yeah. So what happens to that poor woman if and when the crisis house disappears? We've suddenly got someone who will be allowed to escalate her behaviour and probably get picked up by the police and probably get sectioned and probably put in a mental health unit and eventually ruin her life for a significant period of time. So for a very small amount of money and long-term relationships, you manage to get people having happy, healthy lives. I mean, would have thought that return on investment and prevention is so effective.
Amazing. Thank you so much. I'm aware of time, so I'm going to pass back to the chair. I'm sure there'll be further questions around that. Thank you.
Thank you very much.